be talking to you about the literature review behind external ventricular drains, like RUHS monitors and subdural drains. A lot of this will be going over some of the old literature, a lot of the kind of landmark studies that a lot of what we do is based upon. So to start off, these are outlines I pretty much discussed. So external ventricular drains. So this is taken right from the Traumatic Brain Guidelines from the Brain Trauma Foundation's, the 3rd edition in 2007. So at that time, there weren't any level 1 recommendations, but their level 2 recommendations are that in any traumatic brain injury, you have a patient with the GCS between 3 and 8, and in an abnormal CT scan with either hematoma, contusions, some degree of swelling or edema, herniation, or compression of the basal cisterns, that at that time you should go ahead and place in an external ventricular drain. ICP monitoring level 3 recommendations were indicated in patients who had severe traumatic brain injury with a normal scan if 2 of the following were there, and that is age over 40, either unilateral or bilateral posturing, or systolic blood pressure of less than 90 on presentation.
Are there any other guidelines or recommendations for putting in a ventricular drain in a non-traumatic patient?
Yes, there are guidelines for it. There are certainly clinical indications when you have patients with normal pressure hydrocephalus. You have hydrocephalus from tumor compression of the aqueduct. There are many other indications for placing an external ventricular drain, but not that I'm aware that there are guidelines for it.
So the 2010 American Heart Association guidelines for the treatment of stroke recommends that if there is a GCS also of 3 to 8, that you put in a ICP monitoring drain.
Okay, perfect. Thank you. All right, so this study, let me move some of these things out of the way. So published in 1992, so one of the landmark studies that those guidelines are based upon is intracranial pressure, when to monitor and when not to monitor. And what they found were a number of things. Is that, so they stratified patients on a number of things. One was based on the CT imaging. So did the patient have normal imaging, a low density lesion, a high density non-surgical lesion, or a high density surgical lesion? And they recorded how many of these there occurred and then what the relative outcomes were. And essentially what they found, and it's not entirely surprising, that as the severity of the lesion worsened up to high density surgical lesions, you had less good outcomes and more poor outcomes, and more likelihood of becoming, of having mortality. As you see there, it kind of goes from an 18% chance mortality down to a 52% mortality with high density surgical lesions. Now they wanted to also see, did these CT findings correlate with your ICP findings? They also found not surprising results, but important to document. And that is, once again, as the severity of the lesion worsens, you have an increased likelihood of having higher ICPs. So you'll notice here that once you get to high density surgical lesions, you have basically a 36% chance of having high ICPs 21 to 40 and 13% chance of 41 to 60. Whereas if you have a normal CT scan, your incidence of high ICPs in the range of 21 to 40 is 11%, and then 41 to 60% is 2%. So as you get worsening lesions, you have an increased chance of ICPs. What they also looked at is, did this ICP actually correlate with how the patient did? And so these patients were stratified by how their ICP course pursued throughout their hospitalization. So one is that they had normal ICPs throughout their entire stay. One was it elevated at one point, but they were able to control it and reduce it to normal. And the other stratified group was elevated but not reducible. And as you can see, so the incidence of good outcome and a normal throughout is 59% with a 19% chance of mortality. However, elevated but non-reducible showed a 5% good outcome and a 95% chance of death. So demonstrating the importance of ICP. They also further stratified this into whether the CT groups They subdivided them. Let's say if you had a normal CT scan and normal pressure, what was your chance of good, poor, or death by normal pressure or elevated pressure? And also what they were able to find that, and let's say the patients with the high density surgical group, if they had ICPs that were normal, you had a mortality rate of 31% versus elevated 63. Fairly clearly demonstrating the importance of intracranial pressure and its relevance to mortality, control intracranial pressure and its relevance towards mortality and good versus poor outcome. Because as you can see here, a normal ICP course with a high density surgical lesion was a 44% chance of a good outcome versus 17% if the ICPs were elevated. And then they also found, and this is part of the level 3 guidelines from the Brain Trauma Foundation, a number of things predictive of high ICPs. And what they found was that a systolic blood pressure of less than 90 on presentation, either unilateral or bilateral motor posturing, or age greater than 40 were significantly correlated with an increased chance of having high ICPs during their hospitalization. Also noted is that they performed MEPs in this study, which they also found to be correlated with the incidence of high ICPs. However, I don't think many hospitals have the capability of calling in MEP studies on patients.
Tell us about motor posturing, right?
I did. Presence of unilateral or bilateral motor posturing is,
Age?
yes, and age, I mentioned. Yes. Okay.
And then, and the other one was the abnormal CT scan. Where's that?
So this is if the CT scan is normal. This is the incidence of increased intracranial pressure in a patient with a normal CT scan, which is the base behind the level 3 recommendations in the Brain Trauma Foundation guidelines. So this is another landmark study. I basically wanted, this is from 1990, basically taking the CT findings of 753 patients with severe head injury and basically defining imaging characteristics that were correlated with outcomes.
And why did they use the number 753 patients? Because that was shown in the studies to be the power needed in order to make a statistically significant change in outcome. So from that study became the basis of all future studies that said you need
You're trying to divide it by 2.
6 patients in each arm in order to do get a significant study with enough power to say that the one thing that you're changing makes a difference.
Thank you. And so these are 2 graphs taken from their study, in which case they demonstrate that the incidence of elevated ICPs, in this case ICPs greater than 20 is what they define as elevated, was more likely to occur in any patient, whether if they had abnormal cisterns, and that was whether they had a normal CT or no mass lesion on the CT. And then they also show that the midline shift is also correlated with incidence of high ICPs greater than 20. So as the midline shift, as you'll see here, increases, you have a higher incidence of ICPs greater than 20. They also demonstrated that hypoxia was also related. So, or rather, sorry, that the incidence, that the presence of swelling was correlated with, oh, sorry, I misread that. So percent with diffuse swelling were more likely to have hypoxia or incidences of hypoxia on their presentation. And then swelling is correlated with higher ICPs.
So figure 7 says the association of pre-hospital episode of hypoxia and diagnosis of swelling.
I misread that. Correct. Yes.
So that's where we get one of the studies that say a single episode of hypotension or hypoxia is associated with doubling of the morbidity and mortality associated with it.
Correct.
This was part of it.
All right.
That's why we want to have no episodes of hypotension or hypoxia.
All right. And this is just a, it's a graph demonstrating that. So from the study, that so patients with a normal CT versus patients with a normal CT that had developed increased intracranial pressure. So ultimately about increased intracranial pressure occurred in about 10 to 15% of patients with a normal CT scan.
But that says ICH.
Intracerebral hypertension. Intracerebral hypertension. That's how it was on the original. I should have done that instead. And so also...
Wait, can we go back to that? I'm sorry. Go ahead. I'll say it using ICP.
Yes. So essentially that the risk of developing increased intracranial pressure in a normal CT scan is approximately 10 to 15%. So just because you have a normal CT scan doesn't mean you're not going to have elevated intracranial pressure.
This supports my thinking. This was the reason why they said that even though you have a normal CT, but 90, that was the second thing that I talked about, hypertension.
Correct. Okay. All right. And so in another study published in Journal Neurosurgery 1988, this was a study that also was able to demonstrate how control of ICPs was also correlated with morbidity and mortality. So these were patients that had significant elevations in intracranial pressure and were treated with high-dose barbiturate control for them and looking at their outcomes. And so in patients who received barbiturate treatment, in which case the ICPs were able to be controlled, there was a 91% chance of survival with a 8% chance of death. And in the cases where the barbiturate were unable to control their ICPs, they ended up having a 22 out of 23 chance of death. So, or a very high likelihood of death. So basically that controlling of ICPs is very important in controlling mortality. Yes, you look like you want to say something.
So
Maybe.
what's the next slide? Okay, so go back. So what the conclusion of this study was that if the patient is salvageable, that pentabar coma could be used to decrease ICP, and the decreasing of ICP should occur within the first certain amount of minutes that they gave in that paper. But if you can't decrease it, as you said in part 2 of that graph, that you're not going to improve the ICP or improve the outcome at all. But if it's a non-salvageable patient, you also shouldn't try the pentabar coma because it doesn't work at all.
Okay. Gotcha. All right. So next study was also published 1992, actually. 1982. Maybe I should skip over these. I'm looking for time. So
just keep on going. So where you are.
Let's move to subdural drains then. So.
Are you going to go do that other stuff next time?
Sure. Yeah, another lecture.
All right.
So, so this is a study basically regarding the surgical treatment of chronic subdural hematomas in 500 cases, basically documenting clinical characteristics of the patients, their outcomes, complication rates, and recurrence rates, which is very important in what we do and what we discuss with patients. So, epidemiologically, this is typically a disease of patients in their 60s, 70s, and 80s. As we age, we lose brain volume, and the brain is distended from the cerebral veins, and they can easily distend or break, leading to vessels and a chronic accumulation with time. When elucidating the causes of this, most commonly, you would find things such as head injury, alcoholism, anticoagulant use, or arachnoid cysts. If you actually count up all the the percentages, you'll actually notice there's a large percentage missing. And around 40 to 50% of the time, you actually don't even identify a cause. A patient can't tell you that they turned their head wrong or hit their head on something. You'll never identify a cause in about 40 to 50% of patients. Also important to know is the complication rate. So we've already kind of talked a bit about that. So, so you can kind of split the complications into either neurologic complications or medical complications. So the most common complication you're going to come across is causing an acute subdural hematoma, which in this case of 500 patients occurred in 13 of them. You can get a tension pneumo, you can develop an infarct, putational hemorrhages, empyemas as they describe. They don't mention causing intraparenchymal bleeds, but yes, you can certainly do that. And we a lot of times forget about this, but the population of patients that need this are elderly, typically not in great health. So you will get things like pneumonia, you will get things like ileus, and probably underreported or other complications, bed sores, skin infections, all sorts of things that can occur when a patient's not getting out of bed. And so important to know is how do these patients do? So there's this great study that basically evaluated treatment of chronic subdural hematomas with either twistural craniotomy, burr hole craniotomy, or a craniotomy flap, so removing an entire flap to clean out the hematoma. And so this meta-analysis reviewed 48 publications, and ultimately what they ended up finding were some very interesting results. So when you compare morbidity of the procedures, there really isn't any statistically significant difference between either a twistural procedure, burr holes, or craniotomy. That there was no statistically significant difference in morbidity in patients treated with either twistural, burr holes, or craniotomies. Mortality, on the other hand, was significantly different. While twisturals and burr holes had the same mortality, there was an increased mortality in patients receiving a craniotomy. In terms of their cure rate, so how effective is what you're doing to remove the hematoma? And what they found is that in this case, there was no difference between the three, although you can certainly see a trend that the twistural actually has a fairly high percent. It looks around 85%. Whereas as you get to craniotomy, there does appear to be a decreased cure rate, but not statistically significant. Also, recurrence rate, something you need to discuss with patients, is that these things can come back. And what they did find is that there is an increased recurrence rate in patients treated with a twistural compared to either burr hole or craniotomy. However, at least from a standpoint of our institution, our recurrence rate is actually kind of around, I think, 9 or 10%. So they're quoting 33% in this, so that's a bit high. So if we compared our numbers, we're about the same as burr hole versus craniotomy. And then what they did is compared a twistural craniotomy with doing either just the twistural, putting in some form of catheter drainage system, sucking it out, and then removing the catheter and then being done with it, versus actually leaving a drain in place. And this is important because what they found is that while there's no difference in morbidity or mortality, there was a significant difference in recurrence rates. So essentially necessitating the leaving of some kind of catheter in place. As you'll see, there is a 97 out of 142 recurrence rate versus 13 out of 147 if you leave a drain in place, which is why we leave drains in place.
So what is our protocol treating a chronic subdural?
So after placement of the subdural drain, we have them lie flat for 48 hours, turn side to side, Q2 hours, after which those 48 hours they receive a CT scan of the head, and assuming that the thing looks adequately treated and the patient's improved, we typically remove at that time.
Right, because we did a study that showed that if you keep it in for longer than 48 hours, there's no significant improvement from 48 hours to beyond 48 hours. So if it's still a significant subdural, meaning symptomatic midline shift, then we take them to the OR and report at that time. And my personal preference only is that when you have even a large chronic subdural hematoma, I do not take them to the OR right away to do a craniotomy. I still do a twistural puncture of that. I may take them to the OR a few amount of hours after that, but I allow for a gradual decompression. And it's only because of my experience where when I first became an attending, taking them acutely to the OR on 6 different occasions with very large subdural, chronic subdural hematomas, more than 2 centimeters, that the acute decompression led to much further changes, including infarctions of the thalamus, which we had not that long ago, and when we did something like that. So from now on, that's all I do is a twist drill. I relieve the pressure, and then I may take them within a couple of hours, but I will take them later on as well if they don't drain.
And so not only was there a study that basically identified the necessity for leaving a drain in a twist drill, this has also been replicated for patients who've gone to the OR for a burr hole evacuation. So there's a randomized controlled trial in which patients were either left with the drain in place after burr hole evacuation versus not having a drain in place. Similarly, what they found was that, where was the findings on it? So the recurrence rate, there it is. So they had a much, where is it? Cambridge. Yep. So what they found is that there was a significant difference in recurrence rates. So patients with the drain, their recurrence rates were around 9 to 10%, and with no drain in place, the recurrence rates were about 24 to 26%, and that did reach statistical significance. Although interestingly, did they find anything else? I didn't look at so much of the other stuff. Although, interestingly, they have an increased likelihood of being a GCS 15 at discharge when compared to the group without a drain in place. One could presumably, I guess, extrapolate that perhaps there wasn't enough removal of the hematoma by not leaving a drain in place. So now, time permits. Okay, I'll go over some of my pearls. Let's see. So at least with EVDs, things that I consider is, for me, I always do 12.5 and 2.5 to 3.5 in an adult. However, it's really important to remember, as we've stated, not every size is the same, and that will not work in kids, which is why the actual definition of Coker's point isn't a measurement. It's a centimeter anterior to coronal suture and mid-pupillary. That's not of the 12.5 and 2.5. You use the actual definition. Also,
I'm pretty sure we mentioned all of this.
Yeah.
So could we skip this part?
I was going to talk about some of the vectors.
Just say the stuff we did.
Okay, so in terms of being able to guide your catheter in, I always draw a line out from my point of incision to the ipsilateral medial canthus and EAC because that allows me to visualize the vectors, so that when I hold the EVD, I can actually look down the EVD as if it's a barrel of a gun and make sure it lines up in all planes. And that way, when I advance it, I know it's going in the exact direction I want. And what I do that even for a patient that's shifted, because, you know, if I know that the shifting is over to, let's say, the left, and I'm putting in a right EVD, I know where my basic is, where I've done 100 times, and then I know to modify it just a little bit. So I use that as my starting point. So that's typically what I do. Drilling, I always use the guard. It's a little 50-cent piece of plastic that can save you a world of headaches. And I don't think there's any need for having, pride in saying, oh, I can do it without the guard. Just keep it on. Let's see. Oh yeah, tunneling. I think the trocar is the most dangerous instrument in the OR. So after you tunnel it, I always cap it immediately so you don't stick yourself or anyone else. Also take pride in your work. Make sure it's really clean. You want to make it look as if you didn't even do a procedure.
I know that's really, although you say that, it's really against all the current literature to recap the sharp end instrument, right? So nobody's supposed to recap the sharp instrument. What you're supposed to do is put the sharp end into a block that's there so it protects the tip. You're never supposed to recap the sharpness.
Well, we don't have one of those in our. That would be good to maybe put in our cranial access kits, because there's no such thing in there for that, for the trocar end kind of just hanging around. And then the other thing is, after a while, I kind of noticed the only non-sterile thing I was doing in the entire procedure was hooking up the drainage bag. So at the end of a procedure, I'll actually have the drainage bag handed to me sterilely since it's large, and then I'll flush it myself on the field and then plug it in at that point, instead of doing it after the procedure. Oh. All right.